morning, everyone. At the outset, I'd like to thank AIOS for choosing this paper to be part of this wonderful session. It's a very simple paper about a clinical conundrum which I faced while seeing these patients, and I just wanted to share these results with you. So we'll be talking about how what are the changes of Rhokinase inhibitor drops on cases of Fuchs corneal dystrophy. So we all know that this Rhokinase is a molecule which has been talked about quite a lot from Kinoshita's group and other groups after that who have used this in cases which have endothelial issues. And basically the activated Rho-A acts on Rhokinase, divides it into the Rho1 and 2, and this works to phosphorylate various intracellular substances in the corneal endothelium. And it has various actions. So that myosin light chain and the limb kinase acts not only on the stroma, but we know that this drug was initially brought out to act in glaucoma. So it has a lot of action on the actomyosin contractility, membrane permeability, cellular adhesions, cell stiffening, cell morphological changes, extracellular matrix organization, and DNA synthesis. And that has been found to be very effective in patients with glaucoma by increasing the aqueous outflow. Now, a lot of the tests and the studies which have been done are done in the lab on corneal endothelial cells, on in experiment situations, and we would always like to know how that translates into our clinical practice. So over time, it has been shown by groups that it is known to regulate a number of functions in all corneal layers, including the cellular proliferation, differentiation, and modulation, and the cell adhesion, which we know are very important in our endothelial function. So how is the application of this drug? It helps in increasing the proliferation, healing of the endothelium, slowing of the apoptosis, which we know is very integral to this disease, and increasing cell adhesions. So the medication that we are talking about is ripasudil monohydrate 0.4%, which we'll be studying. So as I was saying, there are a lot of papers which are available to us, but many of them are in the lab situation. Of course, there are large groups which have shown it in clinical practice as well. So the purpose of the study was to evaluate the effect and safety of these ripasudil 0.4% drops on the clinical indices, which we see on slit lamp and the patient's symptomatology. And the questions which came up to me was that which stage of the disease does this work best? What kind of changes do we expect? How do we measure these changes? And there has been a lot of work of these drops with DSO, which is just the stripping of the descemetes, and it's shown to work well. So can it over time replace a corneal transplant? So this was a prospective longitudinal study. We followed them up for 1 year, 20 eyes, and we included relatively mild to moderate grades of FACD grade 1 to 4 by the Krashmer classification. Of course, these were patients of FACD. We did not include any other forms of endothelial disease, and we made sure that none of these patients had any pre-existing ocular disease which could confound our results or contribute to their endothelial dysfunction. So apart from our very detailed slit lamp evaluation to try and grade these conditions, we know specular microscopy is our gold standard for studying the endothelium. We also check the pachymetry because we know that they can have some amount of corneal edema. In addition, we did a confocal microscopy to evaluate the endothelium more detailed, and a tear collection to look for any biomarker change that might be there. And we longitudinally followed these patients up for 1 year. So coming to the results, it was very interesting to note that among 20 eyes, now here's where the challenge comes. 14 of these, when we checked by their clinical features, that is their slit lamp examination, their vision, their specular microscopy, they showed no progression. There was no drop in their endothelial cell count, we'll come to that, but clinically on their slit lamp, there was no progression in 14. 4 eyes showed a progression in spite of being on these drops. These were already in a grade 4, and they progressed further, and of these, they are requiring an endothelial keratoplasty to have undergone. Very interestingly, 2 patients showed a very initial reduction in their early stromal edema, and we know that many of these patients complain of early morning changes. Their vision gets blurred early morning when they wake, which improves over time, and they felt an improvement in their symptoms, which is a subjective change. When we come to the diagnostics, there was no significant drop in the endothelial density. Of course, we do not expect an improvement. The pachymetry also remained almost the same. Which brings me to another conundrum which we faced was that very often in these patients of Fuchs, especially because the guttae and the confluent guttae are right in the center, the specular shows up like this, where there's hardly any cells which are visible on the specular microscopy, and even if they show some numerical values, you don't know what to believe. So in cases like this, then how do we follow up these patients and how do you assess whether they're getting improved or not? So that is one point which I thought would be important. When we looked at the confocal microscopy as well, there are a number of changes which have been described in these patients of Fuchs, but there was no significant change over time, over 1 year in these patients, in either their cystic changes or the amount of scarring at the endothelial level. We know that there have been published literature on what are the normal molecular changes in FACD. We did find them to be significantly lower, but there was no change, and that is quite expected because these are parameters which, this is not the pathway where the Rhokinase drops acts at all, so we do not expect any change. One very important thing, and I'm just concluding here, one very important thing is that many of these patients did complain of irritation, and 2 of them had intolerable redness and irritation which made them stop the drops, and 2 eyes showed these kind of epithelial cystic changes which again made us stop the drops over time. So our questions at the beginning of the paper was what stage does it work best, and from our current experience now, probably it works early because in some at least there was a reduction in the edema. The changes would be a clinical improvement more than a specular change. Look out for their side effects which can be, and maybe not yet there to replace a corneal transplant. Thank you so much for your patient listening.
Thank you, Sharon.
Thank you.
So how early, the moment you make a diagnosis of Fuchs, do you start them on Rhokinase inhibitors?
So right now that's what I'm doing. I don't know if it's right or wrong, or we should wait for the clinical edema, and probably that's one of the questions which we could answer. But the understanding is that probably it is the early edema only which is changing, because that is what has been described even in literature, that there has been some reversal of the stromal edema in patients. We're not expecting a cellular change. So maybe, I don't know if it prevents it in any way.
Does it do anything to the intraocular pressure in these patients?
In those patients, there's no significant change. So I have been monitoring because it is an anti-glaucoma medication, but there's no significant drop in their IOP as well, because that would be a problem.
What dose did you use for?
3 times a day. So what has been described is either 2, 3 or 4 times. So I've used 3 times a day for all these patients.
So typically in a patient who is asymptomatic but with Fuchs, would you still recommend Rhokinase?
So for lack of anything else, yes, it's such a slowly progressing disease that we don't know, many of these patients at 1 year, they may still have had the same features even if I had not started Rhokinase. We don't really know, but as of now, yes, I do start them even if they don't, if I find the guttae are, visible guttae clinically, I would start.
And patients who are undergoing cataract surgery now in Fuchs,
Yes.
will you advise use of Rhokinase in
So
them?
again, similar, I do tell them that they have a problem. If it's completely a pristine cornea except for those guttae, then I would probably see them immediately post-op. And it has been described that if you start it early in the post-operative period, if there's little edema, it may hasten the clearance of the edema as well. So there are no hard and fast rules yet.
Are there any studies of using, this is hypothetical, of using intracameral Rhokinase?
No, I've not come across anything like that. That will come a new set of challenges to see.
Would a diurnal corneal thickness help you?
It probably would. It probably would. We know that there is a normal, early morning they're known to have edema.
So you know that.
But that would probably make sense
One
to
of the
check.
things that
Yes. One more thing which has been described is in patients who have very early changes, topography, especially a pentacam, it picks up the difference in central versus peripheral pachymetry, and that could be used as a follow-up parameter over time to see the progression, because other parameters may not pick up the early change in pachy. That's what we checked. So.
Thank you.